I guess I could be an IT person if I needed to be. Okay. All right. Well, a little bit about Tony. Tony is highly recognized as one of the primary thought leaders in the field of case management. Dr. Sussler is a partner, again, and a healthcare consultant at Case Management Concepts, which is a consulting company which assists institutions in designing and implementing and evaluating acute care and community case management modules, as well as she works around strategies for improving cost and care. Okay, especially that reducing costs, we all need that. Dr. Suss has also authored 9 books and continues to be a frequent sought after speaker, lecturer, and consultant in the industry. So, welcome, Tony. And I want to say I personally have attended many of your presentations at various case management and nursing conferences. So, anybody who's been out there as a case manager for a while will know Tony. I continue to follow your work, so I'm particularly excited to have you here today virtually to present. Okay, Tony, now I'll be driving your screen, so just let me know when to go advance as needed.
Okay, thanks, Dana, and thanks, MoreCare, for inviting me to today. I'm so happy to be able to share Case Management Week with all of our attendees today. So happy Case Management Week to everybody. And Dana, you hit it the nail on the head. I've been around for a little while. In fact, I remember back to the days when we didn't have Case Management Week. So It's really wonderful that we are really coming into our own in terms of being a specialty. And I really believe we are a specialty that sits atop whatever our professional licensure is. And so I thought if you would go to the first slide that we'd start off with leveling the playing field a little bit, and just to give you a little bit more of my background, I did get involved in all of this back in 1988. I was finishing my doctorate in nursing, and I decided to look for a job in research, and I was hired by the United Hospital Fund in New York. They were funding 5 hospitals in the New York area to look at delivery models and strategies for reducing cost and improving care. So we're going back to 1988. We're still talking about those same issues, and we're still trying to decipher what those strategies are. So I fell into this thing called case management in 1988. Karen Zander had been already involved for about 3 years, and I connected with her. And I just want to mention she just passed away very recently.
Oh, I'm sorry. I didn't hear that,
Yes,
but I
yes,
knew
very
Karen
recently.
Sandler as well. Okay.
Yeah, it's unfortunate, but she was really one of those first pioneers. Once I began to study the model, and we had a 2-year funded study, and we found that we had excellent outcomes, and so I replicated that study at Beth Israel Medical Center in New York City, and then that's when I wrote the first book. So what I talk about today is many years of experience, not only as a director, but I was also a vice president, a corporate vice president for Northwell Health for case management. And after that, I was a senior vice president at Lutheran Medical Center, where I had case management and a bunch of other departments as well. So I've looked at it from the case manager point of view up to the senior executive point of view. I also started a master's in case management at Pace University. So what I want to say is I'm bringing to you a lot of years of my experience on a variety of levels, and having done it myself as well as worked with other hospitals, we've come to learn over these many years what the strategies are that work the best. And today we're not going to get into the models so much, but I do want to talk about what those best practices are in terms of what case managers and social workers do in this thing we call case management. So I thought, and I'm not advocating for the Case Management Society of America, but they were the first,
I think we're good. I think Andrea's back, so she's going to set up so that now that you are able to utilize the screens. Okay, thank you, Andrea.
Oh, thanks, Andrea. So that means I can slide them, move them myself now, or?
I believe so, right, Andrea? I think you're all set.
Okay.
Yep. Okay, great.
Yep. Okay, take control. Yeah, there we go. Okay, thank you very much. So they did come out with these first standards of practice, and back in '95. And back in '95, this was really the beginning of identifying us as a specialty group. And as I said earlier, it's really nice to know not only do we have Case Management Week, but we've got professional societies, journals, all the things that help us all to remain current in our practices and identify ourselves as that specialty. So the standards of practice provide you with a foundation of knowledge and skills. Now, you may be involved with CMSA, Case Management Society, or ACMA, American Case Management Association. I'm not advocating for one in particular, but again, just to go through some of these foundational elements for you. Let me see if, yeah, okay, great. Yeah, okay. So within their standards of practice, they've got a definition, a statement of philosophy, and these guiding principles. And we'll go through these quickly so we can get into the meat of the matter here. So I think I skipped a slide, but you should be on slide 4 with me. So we're talking about the definition of case management, which they define as a collaborative process, thank you, of assessment, planning, facilitation, care coordination, evaluation, and advocacy. So that gives you a sense of all the different components that go into the process of case management. And also that we work with not just patients, but families as well. And we must promote appropriate use of resources so that we can get to those cost-effective outcomes. So if you could go to the next slide. Oh, am I doing it again? I don't know. Okay, so there's that definition. And moving to the next, yes, thank you. So you can take that definition and you can apply it in a universal manner, regardless of whether you're a social worker, a nurse, case manager, a physical therapist. It doesn't really matter. That definition applies universally. Gives you that case management process. And yes, we do have a case management process. And it really becomes the foundation upon which our work sits. So then they have the statement of philosophy, which talks about the underlying premise of case management is based in the fact that when an individual reaches their optimum level of wellness and functional capability, everyone benefits. And so, of course, our patients do, their support systems, the delivery system itself, and various reimbursement sources. They go on to say, next slide, that case management serves as a means for achieving client wellness and autonomy, and we do that through advocacy and education, resource availability, and facilitation of care, and that it's best offered in a climate that allows direct communication between the case manager, the client, and appropriate personnel. So just to interject there, you know, the early case management models really segued out of the role of the utilization review nurse. And what we learned early on in the late 80s as we were testing these models was that the best way case management worked was if we were going to the bedside and interacting directly with the patient and family. So that is something I have advocated for all these years, and I still think it's really critical to our success in terms of the work that we do. So next slide then. The guiding principles apply to all the roles and functions, using a collaborative partnership approach and always helping our patients to achieve their optimal level of wellness. And so we do that by finding in the post-acute environment the best, lowest level of care appropriate to that patient and their ability to self-manage. And continuing on, we should always, and we do, I believe, use that holistic, comprehensive approach when we manage our patients. And we promote the use of evidence-based care. If you would go to the next slide. We use cultural competence. We work to maintain client safety. And we do that not only while the patient's with us in the hospital, but certainly as the patient transitions to that next level of care. behavioral change science and principles in terms of helping patients to change behavior or apply educational concepts as we care for them, and then, of course, linking with community resources. And continuing on then, we help them to navigate what is next slide, a very complex healthcare system. I've been a patient once or twice, and it is complicated even when you have a pretty, yeah. Hello? It's complicated even when you're
Tony,
helping.
I'm having some sound issues on hearing you. Are you able to hear me?
Well, we're able to hear just fine. Yeah, we're able to hear Tony just fine, Andrea.
Okay.
So we're good.
Tony, I'm just going to pass the control back to you. So if you just double click on the PowerPoint, then you will have that. Okay?
Yep, thanks. Okay. So as I was saying, having been a patient, I can tell you that, and I'm sure we all know how complicated the healthcare system is. The delivery systems can be very confusing for patients and families, and so we do play that advocacy role as we work with them. As case management professionals, and by attending programs like this, you're maintaining your professional excellence, you're promoting quality outcomes, and staying in compliance. Okay. So the guiding principles go through a myriad of different elements, but they're different from what we're talking about today, which are the roles and functions. So the guiding principles, you can overlay them onto every role or function that you perform, but they are not roles and functions themselves. And I like to use advocacy, patient advocacy, as an example of that, because you are a patient advocate whether you're conducting utilization review, discharge planning, patient flow, or anything else that we do as case management professionals. So it's important to make that differentiation, and we're going to go into specifically what the best practice roles are today in just a moment. One of the things we also have to think so strongly about is how we integrate the roles of the RN and the social worker. I have seen departments where the RN does clinical reviews, the social worker does discharge planning. That was not uncommon in the early case management models. Sometimes we see a blended roles. I've been in hospitals as a consultant where the RNs and social workers all did the exact same thing. And what we're trying to accomplish when we really tease out these roles and functions is the ability to help our case management professionals to work at the top of their license and not to have to kind of figure out what they should be doing if they were a nurse or if they were a social worker. So to me, it's fundamental to understand the roles. And for you, regardless of where you work, you understand the foundational elements of the job that you're performing as well. So when we talk about integration, again, we're not talking about everybody kind of doing the same thing. So the first models were simple with no integration, and again, there are still some that do that. Those were the early, more traditional models. But what we found was that allowed for a lot of fragmentation, because we needed to know that the nurse was talking to the social worker, that they were working collaboratively. It was more expensive, and there was certainly potential for things to either fall through the cracks or be overutilized in terms of those resources. So over time, we began to understand that no integration was probably not the best choice. In those traditional models, remember too, we cared over time, certainly into the early 90s when managed care became much more prevalent. We cared more about shortening length of stay. So before that, more length of stay, more reimbursement. Those were the days when, regardless of how long the patient was in the hospital, we got paid for every day. Social work would come in on a referral basis and focus on things like social dysfunction, life-altering events, and sometimes discharge planning and some counseling. I remember working with social workers as a staff nurse, and a lot of times we would pass the home care referral to them, for example. So really all we were asking our social work colleagues to do was fill out some paperwork, which really wasn't, again, optimizing the skill set of that social worker. The nurse having already decided what the discharge plan wasn't simply asking a social worker to fill out paperwork. I think we can better utilize social work skill sets. And in those models, again, does the patient need to be hospitalized? What's the rush? We're going to get paid every day, and maybe sometimes would give a HIN, hospital issued notice of non-coverage, but even that was pretty rare. Then, as I say, we started to move into a better understanding, and we began to see this partial integration where we were starting to put our toe in the water to better understand what some other more efficient models might look like, and would they be more cost effective. And so we began to decide better how to divide up discharge planning, for example, and I'm going to talk about that. Should the utilization review function be done away from the bedside, or should it be integrated into the role of the RN case manager? And we found ourselves now with more and more managed care penetration as well as prospective payment. And really prospective payment in the mid-1980s was the initial driver to move case management out of the community where it had been based since the 1920s. In fact, it's our 100th anniversary this year, moved us into hospitals and then into fixed or case rate payments. And during this period of partial integration, social workers did more aggressive screening, earlier discharge planning, and then we began to see social work taking more and more of a role in discharge planning and less of a role in psychosocial counseling. And why? Because they didn't have as much time to do that as they took on more discharge planning. So this is the evolution of utilization review into case management. And we began not to just look at people coming into the hospital, but whether and at what point they were ready to transition out of the hospital. We also began to look at barriers to discharge and anticipate earlier the patient's discharge needs and discharge sooner rather than later, which was not the original paradigm. And then finally, I'm going to say in the early 90s, probably when I was testing out some of these models, we began to realize that full integration was really the way to go. And we all know the less times we pass the baton from one individual to another, the less opportunity for problems to occur. So we began to realize that fully integrated models were more efficient and more cost effective. But then we got into another problem, and that was caseloads. And as we moved into that era, we began to see caseloads going up, and we also saw that a lot of administrators were saying, well, we don't know who to give this to. We're going to give it to case management. So case managers, in an effort to sort of prove their worth, started taking on more and more and more, and those caseloads went up and up and up. And then people were saying, gosh, you know, this thing doesn't really work. Well, it didn't work when the roles weren't clearly defined, when we were sort of everybody's answer to everything, and when we had too many patients. Nevertheless, fiscal incentives, particularly managed care, really started to drive us to think more efficiently. We needed to get authorizations for discharge planning. We were starting to get more denials. Later on, the RACs and other auditors came in, and then, of course, the initial financial penalties for readmissions. Now, in the value-based reimbursement environment we find ourselves in now, we have additional ways in which we can either be penalized or have less reimbursement. And so there has to be that natural relationship between case management and the financial imperatives we have before us, including cost. So those advances in medical technology, those shorter lengths of stay, and then the use more actively, more aggressively, high-tech home care today. We send patients home much earlier to continue to recover in either that home care environment or some other environment. And with that had to come a greater emphasis on palliative care as well as hospice care. So the paradigm shift for our RN and social work case managers was managing care became the first order of business. So if you manage the care well, if you manage your flow, if you coordinate and facilitate care, the byproduct of that will be a shorter length of stay. So that really, to me, became the number one role that we all wanted to focus on. And then accessing those post-acute care needs as early as possible. Case managers, the RNs, started to look at the more clinically related discharge planning needs. Social workers freed up of some of those clinically heavy discharge planning things that we were putting together for the patients, allowed social workers to focus more on some of those other things, and I'm going to talk about that today as well. So I've been alluding to this notion of a role, so let's talk about what that actually is. It's the key set of categories of the work that you perform as a case manager. They give you the context in which you work, and they can be applied differently in different settings. So these are the current best practice or contemporary case management roles that we are using today in our best practice models. So early on, we called it coordination and facilitation of care, and I like to think of it now as a greater role than even that, although that to me is so critical, but it incorporates this notion of patient flow. And I've been in many hospitals where the hospital's concept of patient flow was sitting in front of a computer screen in the morning and looking at, which beds were going to be vacated and all that stuff. I think of patient flow and coordination of care as something that has to be brought right to the bedside. So I'm going to talk more about that. Utilization management, which is clearly interfacing and communicating with third-party payers, and of course resource management, making sure we're not over or underutilizing resources. Managing denials, not just to appeal them at the back end, but to prevent them in the first place. Variance tracking, you may know it as avoidable days or avoidable delay tracking, and this really is another piece that helps us to manage length of stay and improve quality of care. Transitional planning, when I initially started talking about transitional planning, I was talking about transitioning the patient through the acute care setting, and discharge planning was the movement of the patient out of the hospital. Today, of course, we think more about transitional planning as the movement of patient across the continuum of care. And then we do have a role to play in quality, whether it's readmission reduction, whether it's improvement in delays of care, we do have a role to play. And then those psychosocial assessments and interventions, and of course, social determinants of health, which is one of the newer things people are focused on. So if you think about all those roles we just talked about, how do you perform those roles? You perform those roles by conducting a series of activities or tasks. So those are the functions that live within each one of those roles. They're the specific actions you have to take on to perform utilization review or utilization management, to perform discharge planning. So you must have a series of things that you do. And that's where a lot of the variation can come in as we apply these roles and functions to different models. So let's start with role number one, patient flow, as I just mentioned. And I believe this is a shared role between the social work and the RN case manager. And the idea here is to be as proactive as you can to manage all the patient care processes as that patient moves through the continuum of care. So that could be from the ED to the floor. It could be from the ICU to the floor, from the floor to discharge, whatever that might be. So what do we coordinate and facilitate? Tests, treatments, procedures, consults, and any other intervention. Maybe the patient has to suddenly go to the operating room, anything like that. we should be keeping an eye on in order to not have any time wasted, which is a financial issue, but it's also a quality of care issue as well. So we want to optimize each day the patients in the acute care setting, and to the extent that we can, we want to optimize evenings and weekends as well. So how do we do that? Well, if we can anticipate the facilitation of something in the evening time after we're not there, all the better. If we can, plan for that to happen. And one of the things that is happening more, I'm so happy to say, and I'll talk about it a bit more when we get to staffing ratios, is this notion of weekend coverage. Because we came out of a history of utilization review, there never was a clear understanding of weekend coverage. And so we typically go down to skeleton crew staffing on the weekends. And when we do that, what happens? We do very little. Maybe we get some reviews done. Maybe we get some patients discharged. But we really don't optimize those weekend days in terms of patient flow and so forth. So this is expensive real estate patients live in with us. And I think, I've been talking about it a long time. We're not there yet in terms of weekends, but it's getting better. So you also want to make sure things are happening in the right sequence. So we do have a responsibility as clinicians to make sure that we have things happening in the proper order, and then that they occur timely and without delay. The way we begin this whole process is by assessing every patient on admission. Now, under the conditions of participation for discharge planning, we are required to assess every patient on admission for purposes of discharge planning. But this is also a great way for us to facilitate care by identifying what that patient's daily needs are going to be and coordinating and facilitating those. So we do a paper assessment every day and then a reassessment, and that is probably not on paper, nor would that be realistic, but one of the other tools that I often advocate for is interdisciplinary care rounds. So case managers must participate in care rounds. And by doing that, you streamline your own process. You're hearing what the other team members are doing and what's happening with them on one end, and then you're also sharing any barriers to care or delay issues that you're experiencing from a case management perspective. And you get to meet with the whole team in an organized fashion rather than chasing after one person and another person. So patient care rounds, walking rounds in particular, really is becoming best practice. And based on all that information you obtain, you can put a care plan together where you know exactly what order things need to be done. I mentioned Karen Zander earlier. She was really the first person to come up with something you may remember, some of you, critical pathways. Critical pathways were the first attempt at determining what resources a patient might need on a day-to-day basis in the hospital and working with that kind of a tool. We use guidelines today and other such tools, but they really did start off in case management. Once you know what needs to get done, then you can coordinate those key interventions. If you don't know, if you're not looking at that big picture and you're not thinking about what needs to get done each day and for the stay, then you're not really coordinating care. You also have to coordinate with the family caregivers, of course, and the patient. So we're seeing the Centers for Medicare and Medicaid Services talking more and more about family caregivers. And these are unpaid folks who are helping that patient, either in the hospital, at home, or at any other level of care. And we have to be sure we include them in the process during the hospital stay as well as the discharge planning process. So the other thing that comes out of all this is we identify those delays that might be occurring. And part of our role in patient flow then is to intervene to correct those delays at the moment that they happen and we have identified them. By doing that, you're going to expedite the plan of care, identify those barriers and correct them as frequently as you possibly can. This allows care to happen in a timely manner. It allows the patient to have that smooth experience through that continuum of care and are able to optimize each day the patient is in the hospital. And as I said before, this helps you to manage your length of stay. So I see this role, this patient flow coordination and facilitation of care role, as the most important role that hospital case managers perform, because everything else you do stems from this initial assessment, this initial care planning. Role number 2 then is utilization and resource management, a primary role for the RN. As we talked about earlier, this was the first role assumed by hospital case managers. We had utilization review nurses back in the day. They sat in the nursing station, they looked at charts, they really were not allowed to talk to anybody. They were very isolated. We want to flip that notion on its head. We want you as a utilization reviewer to absolutely engage with the interdisciplinary team. And then, of course, on top of that, when we think about this role of utilization, resource management is now dovetailed with that to make sure the patient's receiving the correct resources and that the appropriate level of care interventions are being applied. So those kind of go hand in glove. When you're performing utilization management, if you're performing it for an insurance company, you are simply sending them clinical information from which they're going to make a decision about whether or not that patient meets medical necessity. If you're performing a review for a Medicare or Medicaid patient not managed, well, then you are performing that role of determining medical necessity and appropriate levels of care on behalf of Medicare. Medicare has delegated that role to case management in the hospital. So it's very important you review both types of patients. For managed care patients, you're doing that to get paid. For Medicare, you're doing it to make sure the patient's in the right setting. You're performing it on behalf of the hospital under the conditions of participation for utilization review. So in order for the hospital to get paid through the Medicare and Medicaid programs, they must be compliant with the conditions of participation. You should see now the intersection of patient flow and utilization, because then you must intervene when that plan does not meet the level of care being provided, and you must make a correction when there is a delay. For resource management, again, it's not just overutilization. Because we have an eye on quality of care, it's underutilization as well. Is the patient waiting for something? Is something not happening that should be happening? What is the problem, and what can I do to correct that? So when we look at cost of care, we're looking at pharmaceuticals and radiology and laboratory and other services that all factor into the direct care of a patient. The goals then are to be sure those resources are being used appropriately, that they're being used in a timely manner, and without unnecessary delay. So if we coordinate care, we manage length of stay, and if we coordinate care and manage resources, we ensure appropriate reimbursement. Role number 3 is denial management, primarily the role of the RN case manager. And as I said earlier, it's not just appealing, it's monitoring and managing reimbursement from pre-admission through post-discharge. So we might be involved with pre-authorizations, maybe billing in terms of Condition Code 44 and other interventions we might apply, and of course appeals as well. We want to make sure that the correct clinical information is in that medical record and that it reflects the care rendered to the patient. Now, you probably have CDI in your hospital, Clinical Documentation Improvement Specialists. You must be sure you have a dynamic relationship with them. Now I see we're finding our CDI staff sort of siloed from the team. And I actually, when I implement models, I bring CDI to the team, to the bedside and to the particularly to interdisciplinary rounds. If the CDI specialist understands what the physician's goals are and what the plan of care is, they can better ensure the documentation reflects that. And so you can also notify them when they might need to query that physician. You want to make sure the information that is needed to be sent to a third party is sent in a timely manner, and you're using some nationally established guidelines to do that, whether it's Milliman or Interqual or some other. And we do that because that gives us a tool, and we must work off a nationally established guideline. And then another technique for reducing denials is to make sure that the patient is transitioned in a timely manner as soon as they no longer meet the level of care that they're in. We must work closely with the pre-cert staff at the front end. And as I said, sometimes we get involved with that and billing at the back end. You may have an internal appeal process either in your department or in finance, or you may be outsourcing your appeals, or maybe you're outsourcing RAC denials, for example, and keeping the rest inside. Either way, you want to make sure, particularly you leaders, that you have good data on what's happening with your denials. So ultimately, the best defense is a good offense. I don't play football, but I know that much. So you want to prevent denials wherever you can and whenever you can. Pre-auths, again, maybe finance, concurrent reviews, case management, billing, finance, appeals, case management, and finance. You, either your department, your leader, your director, whomever, you must have that tight relationship with finance. Role number 4, variance tracking, also known as avoidable delays or avoidable days. I call them variances because you can have a delay in care that doesn't necessarily add to a day. In fact, avoidable delays, to me, really tells the story. These could be delays in patient throughput, actual care delivery that don't necessarily impact on length of stay, or they could be delays in discharge. When you have a patient who's in the hospital and is waiting for something, let's say an MRI as an example, and that MRI is delayed for whatever reason, that's a service delay, and that becomes a quality of care issue, particularly if that MRI is being used to determine what the plan of care will be for that patient. So as you perform this role of variance tracking or avoidable delay tracking, you want to identify those delays in throughput, service delivery, or quality of care. Intervene to correct them when you can. And when you can't do it directly yourself, you want to run that up to your leader, the next person in line above you, whether that might be a supervisor, a director, or even, well, it depends on your chain of command. I was going to say physician advisor, but typically we suggest you go to your director or supervisor first. You should also discuss these delays on patient care rounds so the rest of the team understands what's going on and what you're doing about it. And then finally, it should go into a database in your computer system so that you can analyze that data for performance improvement. These are some of the typical categories we've used over the years: internal hospital systems, so delays in service delivery while the patient's in the hospital, systems or delays outside the hospital. Maybe it's bed availability at a nursing home, or maybe there's a physical therapy shortage somewhere, or there's a delay in getting an ambulance, whatever the case might be. Patient issues, now it could be the patient delaying because decision-making delay, for example, or it could be that they've had a complication in their care. Family issues, maybe they need to bring in paperwork for a Medicaid application, or they've been slow to pick a nursing home, anything like that. Provider issues, providers, yes, physicians, but it could be a staff nurse who's not progressively ambulating a patient or progressing the diet correctly or timely, or not getting a drain out or a Foley out. So any provider, could be a physical therapist, and then payer issues. And these we typically see, again, with those Medicaid delays, maybe for a home attendant, or it could be getting a managed care approval for something. And those are important to catalog because you want the folks who are negotiating your managed care contracts to absolutely know about any patterns that you might be identifying with specific payers, because that should have impact on those negotiations for those contracts. As you collect this data, you're going to find some important single or sentinel events perhaps, but you're also going to find undesirable variations or patterns or trends. And typically it's these patterns or trends that can be most helpful. And again, this would be a whole lecture, but as you collect this data, maybe you're finding specific delays that typically happen over the weekend. And that data can add up to a lot of wasted days. And you need to bring that back to the administration so that they can make a decision as to whether or not there's an opportunity to expand that service when you're seeing those delays. I mean, going back a number of years, we did this with physical therapy. It wasn't that the physical therapists were bad people, but there weren't enough of them, and we saw so many delays. When we started adding up all the days that patients were waiting to start physical therapy, it was mind-blowing, and it was bad quality of care. And patients can decompensate, particularly geriatric patients can decompensate very quickly. So it became very important that we brought that information back. And indeed, our leadership made a decision to hire more physical therapists. Now, that's the best case scenario. But if you don't have the data, you can't make decisions. Certainly leadership cannot make a decision without that data. Role number 5 is transitional and discharge planning. So the focus on the movement of that patient through the continuum and to the next level of care. This is a definition I wrote back in 2002. A collaborative interdisciplinary process of assessment, planning, implementation, and evaluation of the patient's healthcare needs following the current phase of illness. So then that transitional planning means the movement of that patient through the acute care setting, although as I said earlier, folks are using that now in terms of transitioning that patient across the continuum from one level of care to another. They're both appropriate. You must know, as the case manager, the exact moment when that patient is ready to move and coordinate that actual movement. So that all happens within that acute care continuum the majority of the time for us. Discharge planning, again, should be shared between social workers and RN case managers. So it involves the process of assessing that patient after they leave the acute care setting in terms of what they're going to need to make sure that discharge is timely, appropriate, and safe, and that that patient is going to get the most appropriate services that they're going to need in the community. And we should start that on day one, and we start that on day one with that initial assessment. Role 6, quality management, ensuring care is rendered at or above quality standards. And I've given you some examples of where we as case management professionals play a part in quality, because I really believe we do. So we may identify an adverse event. We without getting into too much on readmissions, and there's a lot to say about readmissions, but we have a two-pronged responsibility in my mind as it relates to readmissions. The first is as the patient comes into the hospital, either in the ED or on the floor, we should be looking for the root cause of the reason why that patient returned to the hospital. And then our discharge plan should incorporate the correction of those root causes wherever possible. So if the root cause was because the patient didn't fill their prescriptions and wound up back in the ED, that's something that we may be able to correct. If they had an exacerbation of their illness that was not of anyone's fault, so to speak, then maybe that's not a root cause we're going to be able to correct. But we need to understand what those are. We also, in terms of quality, as I've been saying, we manage the progression of our patients' care toward those outcomes, and that manages quality, as well as correcting delays in care progression also manages quality. So we don't have principal responsibility for quality management. There's a whole department that does that, but we do have some responsibility. Frankly, everyone on the interdisciplinary care team has some responsibility for quality, and so we should all think of ourselves as collaborators in the quality of care process. And now, role number 7, psychosocial assessments and counseling, the primary role of social work. Social workers are best, again, functioning at the top of their license to perform psychosocial assessments and counseling. Could be done by a case manager if need be, and sometimes the situation requires a behavioral health intervention. Psychosocial interventions have become more clearly understood as an important piece of discharge planning, but it's also important to understand it in terms of supporting our patients and families during their stay. So if you think about those very highly stressful areas, the ED, the critical care areas, burn units or trauma units, then you can start to realize how important it is to have social workers identifying and working with those patients. And then ultimately, what are those factors that may be affecting the discharge destination and the patient's ability to be successful in terms of that discharge destination? So if the RN does that initial assessment for the purposes of discharge planning and comes up with the identification of some of those risk factors, and I'm going to show you some examples, then the social worker can pick up that case and do a deep dive psychosocial assessment that would include assessing the family, significant others, social determinants of health, and possibly financial issues or other support issues as well. So the purpose is to help the patient coping during their stay, whether it's a chronic condition or an acute condition. And again, the ultimate discharge destination can absolutely be informed by that information. So what are the social workers' expertise? Biopsychosocial assessments and treatment planning, counseling, crisis intervention on multiple levels, abuse and neglect, domestic violence, substance abuse or trauma, and the identification, again, of those barriers to a safe and timely discharge. And they can collaborate with the RN in the discharge planning process, focusing on the most complex, psychosocially complex patients, and then ensuring that patient gains access to those services. So just to go over that process again, I just want to say the nurse should do the initial discharge assessment, and embedded in that are some things we're going to look at right now, these social work high-risk screening factors. The top is missing from this slide. It should say social work high-risk screen, identification and referral, and you should make this as soon after admission as possible, RNs. And embedded in your initial assessment should be these risk factors. Now you can add to my list or take away from my list. This is just a jumping off point. Adjustment to illness, difficulty coping, a major illness causing a lifestyle change, a behavior management problem, a new prognosis or poor prognosis, end stage of illness, family concerns or conflicts, cultural or language issues, inadequate social or financial supports. You begin to see the kind of things that should be red flags to you as you're doing your initial assessment that would say to you, okay, I need to refer this patient to social work. Issues of non-adherence, ethical concerns, abuse or neglect, multi-system trauma. Now, on psychiatric or substance abuse issues, if the patient has a chronic psychiatric issue, or a chronic substance abuse issue and is not asking for help with that substance abuse issue, you do not necessarily need to refer that to social work. That should not be a knee-jerk referral simply because that patient has had chronic depression for 30 years. You really want to use some critical thinking before you make arbitrary or unnecessary referrals. Same thing with homelessness. My business partner and I like to say if the patient's been living under the bridge for 30 years, is competent to choose to live under the bridge and wants to continue to live under the bridge, then there's no need to refer that patient to social work. Conversely, if they're asking, requesting housing, then some kind of a referral might need to be made. Patients considering long-term care placements or assisted living or adult home. So what we're trying to do here is understand the discharge planning that requires a more clinical focus versus one that requires more of a psychosocial focus. Therefore, you are optimizing these different but complementary skill sets of both disciplines, and that's really what we're all about. So it would look like this. The nurse case manager focusing on the clinical discharge planning. What do I mean by that? Patients going home with home care, patients going home with high-tech IVs or wound management or drains, anything like that, or oxygen, where there's clinical decision-making that's going into that process. Social worker involved in some of the things I talked about in addition to counseling, but also psychosocially intense discharge planning. So patients going to hospice, patients going to a long-term nursing home placement as examples. So now you're optimizing the skill sets, you're unburdening the social worker from some of the discharge planning so that they can actually do that counseling, so they actually have time to do that. And with that, it's going to all depend on, and there's a piece missing from this one, staffing ratios. It should say staffing ratios for RN case managers and social workers, and it will depend on, the staffing ratios will depend on the roles and functions selected, so who's doing what, your model, which we didn't really get into today, hours and days of operation. Are you operating 7 days a week? Are you operating 8-hour shifts, 10-hour shifts, 12-hour shifts? The size of your units, your high-risk social work criteria. Do you have clerical support staff? This is another thing we're absolutely advocating for. We don't want RNs and social workers doing paperwork that can be done by a non-licensed professional. So clerical support is also becoming part and parcel to a best practice model. And of course, software. And it's so wonderful that we have these software solutions today that help make our jobs much more efficient. And we were one of the last departments not to have software. So it's a great thing that more and more hospitals have moved in that direction. So as we're winding up, I just want to spend the last couple of minutes talking about the ever perennial question of caseloads. So for our RNs, you should have an assigned fixed bed of 15 fixed beds. And you know every day when you come in, those are your 15 beds. You're not getting moved every day to a different place. You also need to know that you may actually see more than 15 patients as you have discharges and new admissions. The RN staffing looks like this. And I've given you medical 1 to 15. That would include your subspecialties, your medical subspecialties. Neurology 1 to 15, surgical and surgical subspecialties 1 to 15. Intensive care, you can go up to 1 to 20. Step down 1 to 15 or intermediate, whatever you call it. Pediatrics 1 to 20 unless you're in a tertiary, very high risk pediatric hospital. You might want to think about 1 to 15. OBGYN, usually 1 to 20 is good. Acute rehab, 1 to 15. Observation, you want to move these patients. Your benchmark is 24 hours. So because you've got to facilitate and move things along, we like to see a 1 to 12 for them. For our social workers, it's a little different. Remember, we're using high-risk criteria for referral, and we know from many years of testing these models that 17 patients is the right number based on that high-risk referral criteria. Now, what happens when you have 17 patients that are based on referral criteria is you may need to locate yourself across more than one unit till you hit the 17. We also know, and I've tested this, and I'm telling you with 100% assurance, that if you follow the high-risk criteria set that we looked at, approximately 30% of all your inpatients will match with those criteria. And so that means for 30% of your patients, they're going to have the nurse and the social worker both assigned to their care. And so that would be 30% of all your inpatients, 17 assigned to each social worker. And so because the social workers are assigned based on high-risk referral criteria, and that referral criteria is the same, regardless of where that patient is in the hospital, it's 1 to 17 across the board. I hope that makes sense, and if not, I'm happy to answer questions in just a minute. So your success will be having that strong leadership, certainly having the right number of leaders. I've been in departments where there's just a director, not enough. You must have a director and at least one person under that director, and we're seeing more and more larger hospitals also having case management educators as well. Commitment at the very top of the organization. You're one up if you're one of the leaders of your department and senior executives. The right resources, the right staffing, the right software, everything else that one needs, as well as talented and educated case managers. So I leave you with this. Success means you build a case management system and not just a role. And I do thank you. And I'm going to turn the program back to see if we have questions. Thanks.
Okay, thank you so much, Tony, for that great presentation. And I was, again, I'm dating myself. I was one of the folks that started out in utilization review and it evolved to case management. And that was the thought at that time, is that, well, you know, they're already on the floor. Let them, and we did everything. We did quality. We did what they call now CDI. That didn't exist, but we did it. We just did it all. And then they started, restructuring. But I'm glad you mentioned about you definitely need the tools to perform all of the work that we're doing and to document these delays and everything, because if you don't have the tools, you're pretty much dead in the water. So I'm so glad for technology, because I did also go from paper to a system. And then when I left the hospital, oh my God, in '99, I went to work for a software company for case managers, and I implemented and did consulting and training because I wanted to make sure they had the tools that they needed. So I definitely understood that. But thank you so much for joining us. Now, we do have some questions. However, for our attendees, on the right-hand side of your panel, you should see a quick poll. I'd like you just to answer that question for me. And Andrea, if you can advance to the next screen, what are you currently using for case management? And let me know if you are using paper. I don't think so, but that would be the none there. But while we're letting folks, we'll keep this open for about 1 minute while folks are answering that question. I do want to tell you a couple of questions that we do have here. One of the questions is from one of our customers to say, given the ongoing stress that our current healthcare system is now under, what are the changes in case management delivery do you see on the horizon?
I'm not sure if the question is referring to perhaps COVID. I'm not sure. But
I think it might be COVID, but also a lot of people hear that they're just they're overstressed. Too many patients. They're not doing the ratio.
Well, I know, and it's, as I said, it's been a problem for so many years, and so much of the problem has to do with a lack of understanding on the part of our senior leaders. And I'm not dissing them. It's just that they don't understand. And what they're really not understanding is the value that case management can bring to the bottom line. And it becomes our responsibility to help them to understand that, I think. So that's a job that's easier said than done, and I understand that. But if we don't get to those right staffing ratios So I also would recommend you have a case management report card of some sort where you can show your successes, show your improvements, show how you're affecting financially as well as from a quality perspective, the bottom line of the hospital, so that you can say, hey, look, we could reduce the length of stay by X amount if we had X number of more staff. This is where things are falling through the cracks. I think it really comes down a lot of times to data, and it's a tough one, and I know that. And the other thing I would encourage you to do is use the ratios I just gave you. Right. Because I get asked that question, well, where is this published? Well, I can tell you it's in many of my books and many articles I've written, and you've got it on the slides now, too, because having those benchmarks, knowing what best practice is, can also help sell the case.
Absolutely, absolutely. And folks, someone already asked, can they get a copy of the slide deck? Because they was having some connection issues. People do want to look at that. And also, our poll apparently didn't launch, but go ahead and just put, what you're using in the little comment section there for the Q&A, just so we'll know. All right, so let's see what else we have here. So another question we have here, with SDOH being such a hot topic, do you recommend as part of a standard case management workflow to identify and or document any social determinants of health at admission and then the ED, or what are your thoughts around that?
Yeah. It's an interesting question. I just wrote an article about social determinants, so I did a lot of reading on it, and it's kind of a buzzword. And it's an important thing, but you have to be careful, because once you ask that question, and the questions around social determinants have to do with where the patient lives, their environment, whether it's healthy or not, is their workplace healthy, do they have transportation to get to their job, and things like that, that you working in the hospital are going to have a much more difficult time fixing. So I think you have to be careful about which questions you ask. If you ask the psychosocial questions that we typically ask in case management, and you want to add a little bit on those social determinants, but do school yourself first. And that's why I don't promote strictly switching over to social determinants, because if you really look at what they are, they have to do with pollution. They have to do with all sorts of things, water quality, that go well beyond anything that we could ever do. So you can pick some of that, but certainly don't drop in everything. You won't be able to
that is a great question, or a great answer back. And I know I've always asked the question, like you says, that, okay, so we determined this patient has problems, feeding their family. So what are we going to do? So we really have to be careful. Again, the questions we ask will make sure we can provide solutions for them as well, or at least steer them in the right area. And this kind of leads to the next question. It's regarding the post-acute. As a consultant, do you recommend that facilities should provide some type of continuum or outpatient case management for their high-risk population or chronic care? And they also added, resources, again, are limited.
Love that question. It's one of my favorite things, is to do exactly that. I actually started the department at Lutheran Medical Center for the Medicaid patients, and we did it within our clinic, our health home program. And yes, absolutely, I believe in it. And these models have been tested going back to the late 80s when HCFA funded healthcare.
Oh, yes.
Funded some programs for Medicare patients back in the day. We know that these are cost-saving programs, but again, you have to be able to demonstrate those cost savings to get senior leaders to buy into them. And right now, the way the reimbursement is, if you say to the average leader, "Oh, we're going to stop 20 admissions next month," you're going to set their hair on fire. So you have to just be careful, unless you're in an accountable care organization where reducing admissions is good. But we still get paid on discharges. But is it the right thing to do? Oh my God, yes. And yes, risk stratification in the community using nurses and social workers, and again, identifying whether that patient has a clinical need versus a social need, and deploying those resources correctly has got to be the future. It's just got to be. We're just not quite there yet.
Absolutely. Absolutely. Okay, well, thank you again. Now I'm going to turn it over to Beth Brand. She's our VP of Product and Customer Solutions. Beth?
Hi, thank you. And oh, Tony, thank you so much. This was so informative. I could listen to you for all day long. I really, and I so much appreciate your incredible experience in case management. And some of the points that you mentioned today that really resonated with me were that, integration now is the key, that as case management has evolved as a role and a practice, we've moved from focusing on just that core activity of UR into a fully integrated role where both case managers and social workers are key players, and how the integrated focus now is to proactively assess our patients for their post-acute care needs starting on day one, to optimize every single day that the patient's in the acute care setting, and then to identify barriers and barriers to discharge and anticipate those discharge needs. And also you mentioned that transitional planning is key now, which involves moving the patient along the continuum of care and ensuring that the appropriate resources and services are provided in the most appropriate settings or levels of care. And then one of the other things you mentioned was you spoke about how case managers today play such an important role in denials management and tracking avoidable delays, and that it's not only just the accurate and thorough documentation of those items, but also how important it is to be able to analyze and trend the data in order to recognize issues and be part of the solution. But what I loved is when you summed it up and you said success means you build a case management system, not a role. And I can tell you that at MoreCare, our specialty is in providing automated systems to support and automate the daily work processes of case management, denials management, and avoidable delay tracking. We have a really robust assessment tool that allows you to configure it according to your own needs and includes scoring and trigger events to automatically generate the next interventions and schedule those. And then one of the things we're probably most proud of is that we have just an incredible amount of actionable information that we provide with drill down dashboards. You mentioned a scorecard, and that's something that we are able to provide. So we feel that we serve as an important tool in these processes that you've outlined, that we're kind of part of the team. And if anyone would like to connect with us directly, we would really love to talk to you further. We'd love to provide a demo. And please, you'll see right there on the screen, there's also a link in the chat on the screen. Please reach out to us, and we would love to, as I say, talk further. And Tony, can't thank you enough. Thank you so much for being with us today and for your great presentation.
Yes,
It was
yes.
my
Thank
pleasure.
you, Tony.
Absolutely. Thank you. Thank you so much.
Okay, goodbye, everyone. Thank you for joining us. Bye-bye.
Thank
Bye.
you. Bye-bye.